Welcome to the Rad-On Smart Review CNS Cancer Series.
Glad to be here. Today we're really going to get into low-grade gliomas.
Yeah, we want to cover the foundations, how we stratify risk, and that big question that's been around forever.
Yeah.
When's the best time to treat?
Exactly. It's a complex area.
So let's paint a picture. Imagine, a pretty typical case. A 35-year-old guy shows up after his first seizure, a tonic-clonic one.
Okay.
His brain MRI shows a non-enhancing T2 hyperintense mass, right, insula. He gets a navigation-guided surgery, a gross total resection, does really well. KPS is 100.
Fantastic outcome initially.
And the final path report comes back. WHO grade 2, oligodendroglioma, and the moleculars confirm it, IDH mutant, and 1p19q go deleted.
So the classic oligo picture molecularly defined.
Right. So he's in clinic, feeling great, asking you, okay, doc, what's next?
And that's the million-dollar question, isn't it? The answer is, well, it's complicated. It really boils down to figuring out his risk of the tumor coming back.
Yeah.
That's what we need to unpack.
Okay, let's start with the pathology itself. What makes a grade 2 glioma a true grade 2 glioma today?
Well, the absolute starting point, the modern definition, is it must be IDH mutant. That's non-negotiable now.
And what if it looks like grade 2 histologically, but it's IDH wild type?
Ah, that's a critical distinction. If it's IDH wild type, even if the histology looks low grade, we now consider it a molecular glioblastoma.
Wow, okay, so treated completely different.
Completely differently, aggressively, like a GBM. It's a huge paradigm shift based on the moleculars.
So back to our IDH mutant patient. Once we know that, what's next molecularly?
Then we look at 1p19q status. If it's co-deleted, like in our case patient, that defines it as an oligodendroglioma.
And if 1p and 19q are intact?
If they're intact, which often goes along with ATRX loss, that defines an astrocytoma. Different biology, different implications.
Got it. Oligo versus astro based on 1p19q.
Precisely. And remember, by definition, these grade 2 tumors also lack high-grade features. So no necrosis, no homozygous CDKN2AB deletion. Those are signs of higher grade transformation.
Okay, clear on the pathology. Now, before we even get to what's next after surgery, what's the absolute first step in treatment?
Maximal safe resection, no question. That initial surgery is crucial.
And there's good evidence for that, right? That's not just intuition.
Oh, absolutely. Tons of retrospective data, multiple series, all pointing the same way. More extensive resection leads to better survival. It's really solid.
I remember reading that Jacola study in JAMA. That was pretty striking.
Yeah, Jacola was compelling. They compared resection versus just biopsy.
And the difference was huge, wasn't it?
Massive. Median survival difference was nearly 14.4 years with resection versus only 5.8 with biopsy.
Wow. And didn't it also reduce the chance of the tumor turning nasty later? Malignant transformation?
It did. Almost a 20% reduction in malignant transformation rate. It really highlights that surgery is our first and maybe best chance to significantly impact the disease.
Okay, so surgery is key. Now, the patient's had the resection. We know the path. What now? Treat or watch?
And that decision, that hinges entirely on risk stratification.
Yeah.
We need to figure out if the patient is low risk or high risk.
How do we do that? Is there a standard system?
Yes, the most widely used factors come from an EORTC analysis by Pignatti and his group. These are the Pignatti risk factors. They're fundamental.
Okay, Pignatti factors. How many are there, and what are they?
There are 5, and there's actually a pretty memorable mnemonic for them. SATAN.
SATAN, seriously. Okay, I'll remember that. What does it stand for?
Okay, so S is for size, tumor diameter 6 centimeters or more. A is for age, 40 years or older.
Got it. S-A.
T is for tumor crossing the midline. A is for astrocytoma histology. Remember, oligo is generally better prognosis.
Okay. T-A.
And N is for neurologic deficits present before surgery, and that specifically excludes well-controlled seizures.
S-A-T-A-N. Size, age, tumor crossing midline, astrocytoma, neurologic deficits.
Okay.
How do we use these?
Simple grouping. 0 to 2 factors means low risk. 3 to 5 factors means high risk.
All right, let's go back to our case. 35-year-old guy, DTR. Not crossing midline. Oligo.
Yeah.
No pre-op deficits.
Okay, let's tick them off. Age under 40. Yes. So no A, size. Probably under 6 centimeters if it was a DTR in the insula and not mentioned as huge, but let's assume under 6. No S. Crossing midline. No. No T. Histology, oligo, not astro, no A. Neurologic deficits, no. No N.
So 0 factors.
0 factors. He is firmly in the low-risk
Or it
category.
makes his what's next question lean towards.
Observation, generally. But this whole low-risk versus high-risk thing brings us to that huge historical debate in low-grade gliomas.
The timing question. When do we treat?
Exactly. For decades, it split the community. You had the believers and the non-believers. Kind of a fun way to think about it.
Okay, tell me about the believers. What was their argument?
Well, supported by trials like EORTC 22844, they argued for hitting it hard and early. You know, these tumors are infiltrative. They do eventually progress, often fatally. So the logic was treat early, treat aggressively, improve the outcome, like putting out a fire early.
Makes sense. What about the non-believers?
Their view, supported by the other big EORTC trial, 22845, was different. They pointed out these are often slow-growing tumors in young people.
Right.
And radiation has significant long-term side effects, cognitive issues, endocrine problems. So they questioned if the potential toxicity of early treatment was worth it, especially if survival wasn't clearly improved by hitting it early. Maybe wait until you absolutely have to treat.
So 2 competing philosophies. Which trial gave us the best answer, especially for the high-risk group?
EORTC 22845 really tackled that head-on for high-risk patients.
How was it designed?
They took high-risk grade 2 patients, mostly people with subtotal resections, and randomized them. One arm got immediate post-op radiation, 54 gray, standard dose.
And the other arm?
Observation, they just watched them closely with MRIs and only gave radiation if or when the tumor progressed.
Okay, so immediate RT versus delayed RT at progression. What happened?
Here's the fascinating kind of paradoxical part. For progression-free survival PFS, how long until the tumor grew back? Early radiation won.
By how much?
Pretty significantly. Median PFS went from 3.4 years in the observation arm up to 5.3 years with early RT, so definitely delayed progression.
Okay, so early RT keeps the tumor quiet for longer? That sounds like a win.
You'd think so, but when they looked at overall survival OS, how long people actually live, there was absolutely 0 difference between the arms.
Wait, really? 0 difference. How is that possible?
Median OS was around 7.2 years in both groups, exactly the same.
So delaying progression didn't translate to living longer. How do you explain that?
The key was that salvage radiation, the radiation given later when the observation group progressed, was highly effective. It worked just as well when given later.
Okay, so waiting didn't hurt them in the long run because the treatment still worked when they eventually needed it.
Precisely, and that has huge implications for practice, right?
Yeah, it means for these high-risk patients, you can actually defer radiation without compromising their ultimate survival.
Exactly. It forms the bedrock of shared decision-making. You can sit down with a high-risk patient and say, look, option A, radiation now. It'll likely keep the tumor controlled longer. Option B, we watch closely, use radiation if it grows. Your overall long-term survival outcome looks the same either way.
That's a powerful conversation to be able to have.
Yeah.
Gives patients real choice.
It really does.
Was there anything else from that trial that might tip the balance for a patient deciding between early or delayed RT?
Yes, one important quality of life finding, seizures. Early RT significantly reduced seizures at the 1-year mark.
Oh, interesting. How much of a difference?
It went from 41% of patients having seizures in the observation arm down to 25% in the early RT arm at 1 year. For someone struggling with seizures, that could be a major deciding factor.
Absolutely. Okay, so that's high risk. What about the low-risk patients, like our initial case? What's the evidence say for them?
For low risk, the evidence really points towards observation being the standard approach.
And where does that evidence come from?
A key piece is from the RTG 9802 trial. They had a specific cohort of low-risk patients younger than 40, gross total resection, who were just observed.
And what was their outcome like?
Their 5-year progression-free survival was about 50%.
50%?
Yeah.
So half of them had progressed within 5 years, even though they were low risk.
Exactly. So when you're counseling that young, low-risk patient with a GPR, you can say observation is safe, it's standard. But, and you have to be upfront, there's roughly a 50-50 chance your tumor might start growing again within the next 5 years. It emphasizes the need for ongoing surveillance.
Right. Watchful waiting definitely means watchful. Okay, that's a lot of crucial info. Let's try and boil it down. Time for some clinical pearls.
All right, let's lock these in. Pearl number 1.
Pearl 1. A true WHO grade 2 glioma, definition-wise, is IDH mutant ND, lacks high-grade features like necrosis or that homozygous CDKN2AB deletion. Molecular definition is key.
Pearl number 2. Risk stratification. It's guided by the Pignatti criteria. Remember SATAN?
SATAN. Size 6 centimeters, age 40, tumor crossing midline, astrocytoma histology, neurologic deficits pre-op.
Got it. Pearl number 3. For the low-risk patients, think younger than 40 with a GTR observation is standard, but counsel them about that 50% 5-year PFS based on RTOG 9802.
Pearl number 4, high-risk patients. The landmark timing trial is E06 22845. Key finding, early RT improves PFS.
Right, 5.3 versus 3.4 years median PFS.
But does not improve overall survival. OS was about 7.2 years in both arms. Deferred RT is a safe option regarding survival.
And pearl number 5, don't forget the quality of life aspect. Early RT does offer better seizure control at 1 year. That can be important.
Okay, great pearls. So, thinking about treatment techniques, how does knowing all this about when to treat influence how we approach radiation when we do decide to give it?
Well, it reinforces that radiation is a powerful tool, but EORTC 22845 gives us license to really think about the long-term toxicities, especially in these young patients. Neurocognitive effects, endocrine issues, they're real.
So it allows for a more nuanced discussion, weighing that PFS benefit against potential long-term harm.
Exactly. It's not just if or when, but also carefully considering the long view for the patient's overall life quality.
And that seizure control point comes back again, doesn't it?
Yeah.
It's a tangible benefit of early RT that needs to be part of that individualized decision.
Absolutely. It's about optimizing the whole picture for the patient.
All right, I think we're ready. How about a quick board blitz? Put this into practice.
Let's do it. Fire away.
Okay. Case 1. 32-year-old, GTR of a 3 centimeter grade 2 oligo. KPS 100 normal neuro exam. What's the most appropriate next step? A. Immediate RT to 54 GGI. B. Immediate chemo RT with PCV. C. Observation with serial MRIs. Or D. Biopsy the other side of the brain.
Okay, let's see. 32, so under 40. GTR, oligo, small tumor, normal exam. Sounds pretty low risk.
How many SATAN factors?
Looks like 0 again. Age 40, size 6, not crossing midline, implied by GTR of small tumor. Oligo, no deficits at 0 factors.
So the answer is?
Observation with serial MRIs. Standard for low risk based on RTOG 9802 data.
Perfect. Case 2. 50-year-old subtotal resection of a 7 centimeter grade 2 astrocytoma that crosses the midline. He has mild left weakness. How do you classify him using Pignatti? A. Low risk, observe. B. Low risk, early RTC. High risk, discuss early versus delayed RT. Or D. High risk, immediate chem RT required.
All right, let's run SATAN, age 50, that's 1 factor.
Right.
Size 7 centimeters, that's 2, SAT. Astrocytoma, that's 4. A neurologic deficit weakness, that's 5. Wow, he hits all 5.
Definitely high risk then, so what's the approach?
He's high risk. Based on EORTC 22845, we know early or delayed RT have equivalent OS, so the answer has to be C, high risk, and you discuss the options only versus delayed RT.
Exactly. Discuss the pros and cons, PFS versus OS, seizure control, toxicity, shared decision-making. Okay, last one, case 3. You're counseling that same high-risk patient from case 2. He's leaning towards not having radiation right away. You tell him based on EORTC 22845, deferring RT until progression will likely result in what? A, worse OS. B, shorter PFS but equivalent OS. C, worse seizure control and worse OS. Or D, higher rate of malignant transformation.
Okay, this is the core finding of 22845. Deferring RT means the tumor will likely grow back sooner, so shorter PFS.
Right.
But salvage RT works well, so overall survival is the same, equivalent OS.
So the answer is?
B, shorter time to progression, but equivalent overall survival. That's the key paradox and counseling point.
Excellent. You know, it really feels like EORTC 22845 fundamentally changed how we approach these high-risk patients, didn't it?
Absolutely. It empowered us and patients to have these nuanced conversations about timing and quality of life versus just focusing solely on delaying progression at all costs. True shared decision-making.
And this whole discussion about timing really sets us up perfectly for our next session, doesn't it?
It does. Because while 22845 established the timing debate for RT alone, the field kept moving. Next time, we'll dive into the evidence that actually shifted the standard for high-risk disease towards combined treatment radiation plus chemotherapy.
Looking forward to that. Okay, so let's quickly summarize today's key points on WHO grade 2 gliomas.
We started with the definition, gotta be IDH mutant, no high-grade features, molecular is paramount.
Then we covered risk stratification using the Pignatti criteria, remember, SATAN, to sort patients into low and high risk.
For low-risk patients, observation is standard, backed by RTG 9802, but keeping in mind that roughly 50% 5-year PFS.
And for high risk, the big takeaway from EORTC 22845. Early RT improves PFS but not OS, making deferred RT a safe option from a survival standpoint, though early RT might help with seizures.
A complex field, but hopefully that provides a solid framework.
Definitely. Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next session. Thanks for tuning in.